Yeah.
Okay, so if you look real close, you could see a little microscopic wire in there. Those are little sensors.
Okay.
That's if there happens to be an alarm, or if it picks up temperature changes or any fluctuations of anything, it will send it to the control unit, pause the ultrasound, and give an alarm.
Okay.
That's the whole purpose of that. Okay.
Okay.
But proximal and distal marker, treatment zone.
Right. And so if you hold that to my leg, I can treat, if it was a tibial, although I wouldn't treat a tibial most likely with that.
No.
But if pop, I can go from like pop to
Absolutely.
common with that whole area.
Yes.
Okay.
And for arterial, I'll show you a little trick too that we can go over if you like.
Okay.
So proximal and distal markers. Coolant comes out the very distal end. So once you advance this up and over the wire, you will have the ultrasonic wire within its little carriage, okay, prepped and ready to go too. They'll prep it within inside the chamber, and they will flush from the inner portion here
Okay.
to bathe the ultrasonic wire.
Okay. So after
3-4 cc's.
So then we take the ultrasound wire. Yep.
So
And then at this point, so the catheter's in place. We take the wire out, and now
Yes.
it's just the catheter. Right.
right, and if you have an arterial case, if you're up and over, and sometimes they can be real tight, I suggest that you attach a 10 cc or a 20 cc syringe to the coolant port.
To the coolant port. Okay.
Just in case if you're advancing, because I'll show you in our brochure, if you're advancing and you feel any resistance at all, pull back a couple of centimeters, start flushing the coolant port. Of course, some of the water will come out here,
Okay.
but as you're advancing,
It might make it
it
easier.
may expand, because there's tracks, three
Okay.
tracks within our device.
Okay.
And it may expand that catheter to allow our ultrasonic wire to traverse a little easier.
Okay.
Because after a 30 centimeter device, I'll show you too, you can't really see them that well, but each one of these little dots represents part of the ultrasonic transducer. So after a 30 centimeter, which is 1 centimeter apart, a 40 and a 50, a 40 is 1.4 and a 50 is 1.7 centimeters apart. So there's that separation, so it makes the wire a little floppier.
Okay.
And may not advance as easily. That's why I have that syringe attached. You feel any resistance, pull back, put the syringe, start flushing, and advance nice and slow. If you still feel resistance, you can always pull your sheath back right to the tip of our device, depending where you have the sheath placed. So say if you have a rabies, a 45 or a 55, just pull it to the tip there.
Okay.
Advance our wire to the tip already, so as you advance the sheath a little bit, up and over a little more, you can advance our device that has the ultrasonic wire already in it, and sometimes that may help.
Okay.
Okay, that's just a little troubleshoot. So you advance the wire. Now it's a 1-to-1 ratio. You don't have to fluoro unless
It'll
you
just
feel
go
resistance.
until it gets to.
And it locks in. Of course, this is a demo, but usually it's
It'll
a lure
lock in
lock.
there. Yeah.
It'll lock right in, just like a regular three-way.
Okay.
It'll lock right in, and it's a 1-to-1 ratio. And if you look, you could see the ultrasonic transducers a little better now.
Yeah. Yeah, I can
Okay.
see them. There's this one, right? Those little, no, those are the
They'll-
transducers.
30, 40, and 50 will always have 30.
We'll have 30 of them. It's just the spacing alone.
They 40 and 50 will be 1.4 and 1.7.
Okay.
Okay, that's the difference. That's why I was saying sometimes it might be a little harder to advance.
Sure. Okay.
Okay, makes sense?
Yeah, yeah. So far, so
Okay.
good. Yeah.
So, say we had this in place. So you'll have some of it, say on the outside of the skin,
Sure.
part of this. So I have them loop it. You can loop it and secure it with steri strips.
Yep.
Or some facilities will go with like a figure S and do it that way with just straight up tegaderms.
It's fine.
If you can, try to remember, especially for groin sticks or popliteals, try to keep a window open with the tegaderm so they could see if there's any swelling. You could put a 4x4 underneath to make
Okay.
it comfortable for the patient, of
Yeah.
course, but keep the first tegaderm over so they see a window and see if there's any bleeding or swelling.
Okay.
And then they'll be able to call and say,
So
hey,
instead
there's
of
a
putting
problem.
like a steri strip from like here down to here, you know how people sometimes loop it?
Yes.
Maybe just take a tegaderm and just lay it over this whole thing as one piece and not steri it right there to here, right?
Right. There's a couple of options.
Yeah.
You can take the steri strip and bring it like a butterfly
Okay.
and just have it, instead of looping it around.
Yeah.
Some facilities, I've seen what they do is they'll secure the sheath,
Mm-hmm.
then they'll do a figure 8 around our device.
With suture or with the suture? Yeah.
And then they'll come back around the butt end of the sheath and then come back like a figure 8.
Just to keep it from
It
moving.
keeps
yeah.
it extra secure, but you have to make sure that they don't put it too tight,
Otherwise
because if
it'll-
you crimp this too much, you'll have nothing but alarms.
Okay.
One of the options.
All right.
Okay, so they secure it to the skin.
Mm-hmm.
Now, if you want, in this area, you can have 4x4s, so when they go to remove it, it will be a little easier.
Sure.
But towards the catheter end here, if you
Yeah.
can keep that just tegadermed,
Exposed, yeah.
right, exposed, so they're able to see the coolant and the drug port.
Okay.
Okay.
Gotcha.
What I've been noticing over time is some facilities used to put a bunch of towels and
Mm-hmm.
stuff over it.
Yeah.
They're all coming to the same conclusion: less is better.
Yeah. Be able to
Just
see more.
put a 4x4 there to make it a little simpler
And
when you
tegaderm
remove,
to see
and
it.
tegaderms, and secure it,
Perfect.
because this way they can see it better.
Yeah. Gotcha.
Okay.
All right, so now everything is good so far,
Mhm.
and these two things are what goes into here.
Yes.
That's what the simulator was
Correct.
for there. Gotcha.
But never hit start
Until these are attached.
until the fluids are attached and running,
Okay.
because you will have an alarm.
Okay. So after everything's in place, like
Mhm.
my job is done, so to speak, everything, I'm happy where everything's located, then I hand this off. They will connect it, but not hit start yet. We'll have the pump going with the fluids going in, and then once everything is going, then hit the green start button.
Yes.
Okay. And that's it.
Yep.
Now, what about the order of, is there like like the coolant versus the drug? Does it matter, or?
You can do coolant or drug, whichever you prefer first. But
Okay.
the one thing that you have to remember, once this device is placed,
Mm-hmm.
every 5 minutes,
Mhm.
you want to make sure that you flush forward only on the coolant and the drug port. I always tell everybody, be positive, don't be negative, because if you pull negative,
Mm-hmm.
you can draw a thrombus back into the coolant or drug port.
So plug it.
Exactly.
Okay.
So I always just
But
tell
was there
everybody,
like a time frame? Like I remember like hearing that you have like within
5
5 minutes. Like once you get the catheter in place, you have 5 minutes to get the ultrasound wire in place, or 5 minutes from the time the ultrasound wire is in place to the initiation of the actual, you know what I'm trying?
No, right.
So-
That's a good question. The question is once you have the ultrasonic wire in and in
Yes.
place, and everything's in place the way you want, you have 5 minutes before you flush the drug in the coolant port.
Okay.
So every 5 minutes,
Shouldn't
flush
take that
forward.
long, right? I mean,
No,
once everything's in
shouldn't,
place,
but-
you should be able to get this, make sure everything's running, hit start, and you should be good to go.
Now, some places will want to make sure that everything is secured to the patient and covered up
Yeah.
before they do the hookups. So that gives them the 5 minutes, so they'll probably flush once
Flush
prior
once.
to the connections.
And just the coolant. No, you could
The
flush
drug
both, but
and
flush
the coolant,
forward.
yes.
Okay, with heparin saline.
Yes.
Okay.
And of course, if you want, you can have them flush the sheath in the meantime as well.
Okay, so then the only two things that are coming off of here would be the coolant, which is one of these, the saline, just
Mhm.
saline.
Yes.
And the other one is the TPA, and there'll be a connection that'll go to here, these two, right? These stopcock ones.
Yes.
Okay.
And your minimum for your drug is 5,
Mm-hmm.
and the maximum is 35.
Okay.
For your coolant port, your minimum is 35, and your max is 120.
Okay.
So you may get an alarm occasionally, depending if you were able to get that tip through the thrombus.
Mhm.
If you were unable to get it through that thrombus, you might get an
Mhm.
alarm, which would be a temperature.
Okay.
And you could just have them bump it up 10 milliliter increments
Okay.
until it stops alarming.
Now, if there's a long thrombus and the 50 doesn't reach the whole thing, in general, treat closest to you and then work distal, or do
If
you?
it's DVT, yes.
Right, because you always want to try to open up like the main common femoral before you go up to the iliac anyway.
Yes.
That'd be the goal.
Yes.
If it's, let's say it's SFA all the way down to the pop, but it's long enough where the 50 doesn't quite make the whole distance,
I would start
down
distal.
here. So you
Yep.
want to get it like just past into the normal, like, you know, and you can do an angio to confirm through it that
Yep,
we're
you
in
shoot
the.
through the sheath
through the sheath.
before you place our device. See where you want to start.
Well, yeah, and then let's say I get your outer catheter without the ultrasound through the sheath, over the wire, into the non-occluded part of the artery, and I want to make sure that I'm intraluminal. If I take that wire out, can I take a little bit of contrast and
Yes.
inject it through that
Well,
catheter?
if you're talking arterial.
Arterial,
yes.
yeah.
Yes.
And then if I'm happy, then I can put the ultrasound, wire into it, and then all the rest of the steps. And then come back the next day, and if that looks good, but I still have some more, just back it up and
Yes.
continue. Okay.
Yes. Now, just a little FYI, if you have an arterial case
Yeah.
and say a graft shuts down mid SFA, so you want to use a 30 or a 40, say, but you're afraid that you may have some showering effect distal,
Yep.
you can still hook up like a piggyback for your coolant, run the coolant at 25 and TPA at 10, and TPA will still come out the distal tip here, and you still have your equivalent of 35.
Okay.
Does that make sense?
I think it does, yeah.
So,
'cause
like, I've seen it where sometimes they'll park it in, like, in the anterior, just right at the junction, because they're still trying to open that part up, but they also have thrombus just above that.
Okay.
So you can have that, you can have the best of both worlds, so to speak.
Okay. All right.
Does that make sense for
Perfect,
that?
yep.
Now, for your DVT, obviously, you're going to want to treat, like, say, right from the sheath. Where's our radial peak marker? Here's our radial peak marker. So if you want, you can have it right at